right. Hello, everyone, and thank you for joining today's webinar, How State Palliative Care Advisory Councils Are Advancing Serious Illness Policy, brought to you by us at NASHB with the generous support of the John A. Hartford Foundation. So before we jump into their content, we'd like to take a couple minutes to go over some webinar and Zoom logistics. So you are all here as attendees, which means that your video and microphones are off unless we turn them on at the end during the Q&A session for you to ask a question. You may use the Q&A function at the bottom of your screen to submit questions and comments throughout the presentations, but we will wait until the end of all the presentations to answer all questions. And the slides and recording from today's webinar will be posted within the next few days on NASHB's website. So here is the agenda for today's webinar. First, I will hand it off to Scott Bane from the John A. Hartford Foundation, who we thank for their generous support of NASHB's palliative care work. Then I will provide some background on NASHB, our palliative care work and resources, and palliative care and serious illness councils across the country. Next, we will hear from 3 state palliative care and serious illness councils from 3 different states, Maryland, Maine, and Texas. We will then conclude with a Q&A session from the speakers. And so with that, I will turn to Scott Bane to say a quick welcome and a hello.
Thank you so much, Ella. I'm Scott Bane. I am a senior program officer here at the John A. Hartford Foundation. We are a proud funder of NASHB and very pleased to be sponsoring today's event focused on how state palliative care advisory councils are advancing policies that support access to high-quality serious illness care. The John A. Hartford Foundation is a national philanthropy. We are based in New York City, and our mission is to improve care for older adults. We do this by working in 3 priority areas: building age-friendly health systems, supporting family caregivers, and improving serious illness and end-of-life care. On behalf of all of my colleagues, I want to thank NASHB, the state officials and council members from Maine, Maryland, and Texas, and most importantly, everyone joining in the audience today. I was just presenting last week to the Texas State Palliative Care Interdisciplinary Advisory Council, and I got to hear firsthand about the critical role that these councils play. It's important that more people know about them and that other states have a pathway to create councils like this if they are interested. Today's session is part of a grant from the John A. Hartford Foundation that supports NASHB in building state policies to improve care for people with serious illness. We hope that you'll take advantage of and spread the word about all the great resources that NASHB has been and is creating. And I will leave you with one other free resource that I hope you'll take advantage of. It's an upcoming webinar series on how to effectively communicate about palliative care, hosted by the National Academies of Sciences, Engineering, and Medicine's Roundtable on Quality Care for People with Serious Illness. The first webinar is May 20th, and we'll discuss how to address public misperceptions about palliative care with evidence-based principles. You can find out more information about this webinar and other resources by subscribing to johnahartford.org. So again, the foundation is so pleased to be supporting this great work that all of you are doing. And with that, I pass the baton back to you, Ella. Thank you, everyone.
Thank you so much, Scott, and thank you to the John A. Hartford Foundation for their support of this work. My name is Ella Taggart. I am a senior research analyst on the Aging and Disability team at NASHB. For those unfamiliar, NASHB, or the National Academy for State Health Policy, is a nonprofit, nonpartisan organization. Our vision is to improve health and well-being of all people across every state. And our mission is to be by, of, and for all states by providing nonpartisan support for the development of policies that promote and sustain healthy people and communities, advance high quality and affordable health care, and address health equity. We work to accomplish our mission by supporting states in the development of new policies and programs, by surfacing and disseminating best practices among states, strengthening partnerships across state agencies and executive and legislative branches and the private sector, and by elevating the state perspective for a wide range of groups, partners, and the public. And so NASHP publishes a variety of resources related to palliative care. They're all available at nashp.org/palliative-care. And so I'm just going to highlight some of those for you all. We regularly update 3 50-state trackers on palliative care. One tracks palliative care and serious illness advisory councils, like the ones that we will discuss today. One tracks palliative care information and education programs across states. And one tracks legislation and budgetary action in states related to palliative care. We also have an amazing state resource guide with 3 parts, one on connecting patients to palliative care, one on supporting a palliative care workforce, and one on paying for palliative care in states. And this guide is an amazing resource for different ways states can support palliative care. Currently, 6 states are participating in our Serious Illness Institute, which is connecting states with palliative care payment and data experts to explore the development of a Medicaid benefit. 3 of those states are here with us today. And we also have other great resources for anyone who's interested in state work in palliative care. And you can stay updated on all of these resources by subscribing to our palliative care newsletter. And the link for that is in our website as well. And Salam has also just shared it with you all in the chat if you're interested in accessing any of those resources. So with that, I'm going to show you a quick look at state palliative care or serious illness advisory councils across the country. So as of March 2024, 24 states have legislation around a palliative care task force or council of some sort. And I'll briefly note that this image is from our 2023 tracker. So one state on the map has a council that is since sunset, but 24 is our most up-to-date number. And these councils, as many of you know, tend to vary greatly across states in what they're called, in how long they've existed, in who their members are, in how active they are in the palliative care work in their state, and how often they're convened. But despite this variation, they do tend to share a common goal of expanding awareness of and access to palliative care and serious illness in their states. So for those states who don't have councils and for others who are interested, these are some of the types of activities in which state palliative care councils might engage in. They might work to advance palliative care legislation. They might create reports on the status of palliative care in their state. They might help bring awareness and education to the public on palliative care through websites and other information campaigns. They also might provide recommendations as a council to the state on where they feel palliative care policy and programs should go in their state. And so now, with all of that background information, we're going to hear from 3 state councils. These 3 states are in our Serious Illness Institute that I mentioned previously, and they provide 3 strong examples of councils that have made great progress, though they each have gone about their journey in a slightly different way. So we're excited to hear from them on their different experiences. And so with that, I am going to pass it over to Marilyn.
Thank you very much, Ella.
Yeah, thank you, Chris Kearney. I'll introduce myself and turn it over to Paul. I'm a family practice trained physician who's been doing palliative care for about 20 years. And I am on our council for the past 5 or 6. I'm the chair of the council. Paul has the institutional memory, so I'm going to let him tell where we came from.
Yes, that is correct. I do have that memory for most of the council's existence. My predecessor, Jack Schwartz, actually was one of the people who helped create the council back in 2002. And I joined in 2008, took over his duties as Counsel for Health Decisions Policy for the Maryland Attorney General. And what I do is in terms of the council, is provide some staff support, and I'm the Attorney General's designee to the council. So yes, I can give some background and history of how the council's evolved and where it came from. So the council was established in 2002, and preliminary to that, there were grants and there were committees, and the thought was to have a permanent body and to put it into statute and have a permanent body of a diverse group of practitioners, consumers, religious groups, lawyers, all the people you might expect to see when these controversies appear in the legislature or before state agencies, and to have a body that has some expertise that could advise state legislators and department heads that actually engage in policy in this area, such as health and aging, et cetera. So this is what the vision was, and I will take you in the next slide through some of the notable achievements, but we'll go back to that last slide for now. So in the statute, there's a mandate to advise legislatures and key agencies, which is very important. In fact, we have legislators on the council, which has been very vitally important to getting important legislation through, because those representatives are often instrumental in doing that. And key agencies, we need their input, because actually, if you're going to actually see something come to fruition and be implemented, you're going to need the actual agencies with the actual funding, the actual money to do it on board and with you. And then, so we also, the council's mission is to monitor care for life-limiting illnesses. So the council is a vehicle for people to come to the council with their concerns, and the public is invited. We have very engaged members of the public who come to our meetings, and we get a lot of good give and take. And the idea too is the council, part of its mission too, is to participate and promote educational efforts in advanced care planning and palliative care, all these efforts to improve the quality of care at the end of life. Now, originally that was the name, and it has been, or is in the process of being changed, because the legislature passed a change to our name this last session to make more of the emphasis on palliative care. We have a website that the Attorney General keeps for the council. So we have this very close relationship with the council at the Attorney General's office. So the council's website is within the Attorney General's site. And on that site that you can find past minutes, you can find documents that they've created, reports that they've created. There was an article written by my predecessor and one of the original chairs of the council, Cinda Rushton, back in 2011, that talked about the council's evolution and development and successes and challenges to that point. And it's actually a very informative article for anyone who's considering doing this as a real thing you want to do in your state. I really suggest reading that article. It's very informative, and it really thinks through a lot of these issues. Okay, so we can go the next one. So past activities of note. Early in the council's life, they prepared a study of healthcare services for children with life-threatening conditions. The idea of being hospice care, palliative care for children with very terminal illness, and the importance of that. And they worked with Johns Hopkins at the time, and that also is referenced in that article that I talked about. So one of the great things about a council like this is if you have the gravitas, you can work with people and issue reports, and then recommendations can come out of that report and go to the legislature and go to the agencies, and they have some confidence in what's being told them. And in that vein, the council initiated the exploration of our Maryland MOLS form in Maryland. So what we did there was, with the council in concert with the Attorney General's office and the health department and our emergency medical services agency, all worked together and consulted with many different healthcare providers, lawyers, consumers, everybody in the state about what the form should look like. And we developed a form, and then we went to the legislature pretty much with a form in place with everyone on board. And we got the legislation through, and then we had regulations that implemented the most legislation. So that's one good example where you have a number of people from diverse backgrounds already on the council to give you feedback and to kind of point you in the right direction. And then more recently, we had a report that the council issued in 2020, making recommendations to increase the use of electronic advance directives, to get these data points so that you can easily access advance directives and Maryland Moles forms and that sort of thing. And so this is now turned into legislation that a council member, a senator council member, state senator council member, put forward and got passed, that then had the Maryland Healthcare Commission, our commission, actually take the lead on this and implement a lot of these recommendations to create a platform. So there are a lot of opportunities, even for an advisory council with no real money, but with credibility and with research and passion with its members, to actually make a difference. And the next one, I'll let Dr. Kearney take over. And
Yeah.
you can comment on anything I've said to this point too.
Thank you. Yeah, thank you, Paul. I would comment briefly, I guess, and we'll talk about this maybe even later. There's some advantages to being an old organization as opposed to a new one, but there's some disadvantages, and keeping the ball rolling over the years is, of course, a challenge for any council or organization. So we may touch on that. I think to great advantage for us, the legislation mandated that we have certain obligations, I've taken them as anyway, to report to, for instance, the Secretary of Health in Maryland, the Secretary of Aging in Maryland. So when we call and say, we're obligated to talk with you, they say, sure, come and talk with us. So it's been useful to have that in as part of our mandate. So as Paul's pointing out our current activities, the state of Maryland back in 2016 mandated that every hospital over 50 beds had to have a palliative care program within their hospital setting. This recent effort was to follow up on that for community-based, and so we were involved actively with the Maryland Healthcare Cost Commission of surveying the state of Maryland to find out what's out there in terms of palliative care across the state. And as you might guess, something's good, something's not so good. So we did get our name changed from the State Advisory Council for Quality of Care at End of Life, which seemed kind of limiting, to this, to the Council on Serious Illness Care, done by a council member who is also a state representative. Good idea on your council to have a state representative. As Paul is pointing out, we have this promotion of advanced care planning. Definitely, most interestingly to me, in the last year or two, we've been involved in a dark corner of healthcare in the United States and in Maryland with prison health, and recognizing serious illness within the prisons and attempting to try to improve the situation there. Not so simple, as many of you probably already know. Most interesting is our NASHB involvement with serious illness Institute, with the big goal of obviously promoting palliative care services or financing a benefit for palliative care services wherever we can find it. Briefly, I know I'm running out of time here, but we're hoping for a Medicaid benefit, which we may talk about in a little bit later. Unfortunately, the state budget is kind of backed up, and that may be somebody else's states too. So we're interested in another approach, but we're very interested in the financial backing, which is the root, in my opinion, to spreading palliative care services across your state. That there has to be a financial argument that has to be sold at many different levels with probably a broad coalition. So I think the council is a good springboard for that. I think I'll stop there if I don't know if we're out of time at this point yet. Maine.
Hi. Okay, my name's Lauren Mikalakis. I am a palliative care physician. I worked in hospice and palliative care for about 25 years, and my present role is as a consultant with the Office of Aging and Disability Services through Maine DHHS. I'm representing my role on the advisory council and my role as ex-clinician more than as representing government here. Next slide. So our palliative care advisory council came into being only since 2015. Our main chapter of ACS CAN had been playing with this terminology and this legislation, and collaborated with our Maine Hospice Council to secure passage of LD 782, an act to improve the quality of life of persons with serious illness. And within that legislation, it established the creation of the Palliative Care and Quality of Life Interdisciplinary Advisory Council. It identifies 13 individuals to be appointed by various members of state government, as well as the Maine Hospice Council, representing multiple disciplines involved in the delivery of palliative care services and those vulnerable populations who would benefit from it. In the legislation, we were convened by the Maine Hospice Council with its executive director named as a non-voting member. And this was extremely fortuitous because the Maine Hospice Council and its executive director, I will name her, Candace Powell, has been in the environment as executive director of the Maine Hospice Council for over 30 years. So with that, we seem to have immediate credibility. Candace runs everything hospice, has done that for years, including our own prison hospice program, including our Pulse Coalition, all that work that we've been doing within the confines of the Maine Hospice Council, and then bringing with it also rich relationships that Candace had with various members of government and other state agencies. In 2023, LD 782 was amended to add an additional member representing consumer and patient's family voice. I can't believe they forgot that one, but we've corrected that. Next slide. So within the statute, the duties of this Palliative Care and Quality of Life Interdisciplinary Advisory Council, which is way too many words for me, but it is what it is. Our prime duties are to consult with the Maine CDC on matters related to the status of palliative care. We have to analyze palliative care in the state. We have a responsibility to make recommendations to improve palliative care and quality of life in persons with serious illness, and to submit a report to the various legislative committees by January 1st each year with our findings and recommendations. And then also in the statute, a later paragraph says that palliative care initiatives, we can do palliative care initiatives to the extent allowable by available resources. So within those words, we certainly have our responsibilities to do bullet points 1, 2, 3, 4, but then we're free to go about taking part in other activities to support this work across the state. Next slide. With no funding, which has been a challenge all along. Candace is extremely resourceful, and she, with the leadership of the advisory council, have been successful in securing some private funding and grants to do some of the projects along the way. Next slide. So included in this list of things that we've been able to accomplish over the years, we started again very, very slow. I mean, I was talking to some of the other panel members earlier that when we first got together in 2016, there was this sense of excitement and this sense of now we can really do something. But as we looked around the room, we weren't really sure what it was, especially because there was no funding, and especially because most people had full-time jobs and didn't have an awful lot to give, as much as they would like to give to this. They probably had limits in their own lives. One of the first things we did was secure a little bit of funding to do a prevalence of palliative care survey across the state. We learned that only 27% of our hospitals had palliative care programs, and that there was very little of expansion of palliative care into community-based settings. This was repeated in 2022. We did a little bit of exploration, like what are the barriers to workforce, what are the barriers to the expansion of palliative care in our state? And certainly we identified things like lack of awareness among providers, among health systems, among patients and community members at large. We identified a lack of sustainable reimbursement. Even in that first survey that we did in 2016, we identified that there were, programs in some of our most rural hospitals, but, you know, there were maybe just one doctor working alone or one social worker being the palliative care team. So what we learned in 2016 was not only was there not enough palliative care, but there was not standardization, right? That a palliative care team should be interdisciplinary and it should be guided by standards. And if you look at one palliative care program, it should look similar to another palliative care program. So that was one thing that we identified way back in 2016. We repeated the survey in 2022 and found that we still had most hospitals not having palliative care programs. I think we had moved it up to like 32 or 33%. But we did see that a lot of these programs in these hospitals and hospital systems had taken on more patients and they had taken on more settings, where in 2016, we saw very little penetration into community-based settings. We now see a fair amount of home-based and community-based palliative care being distributed in at least some of the less rural parts of our state. Maine is a challenging state. We have two things we're famous for. Besides lobster, probably, we're famous for being the most rural state in the country. We're also the oldest state in the country. And both those things are going to put additional challenges and stresses on the existing palliative care resources. One of the things that we did early on, we provided some clinical leadership while collaborating with healthcare system leaders in our state to create a statewide palliative care Project ECHO, which meets once a month in the typical Project ECHO format. You know, start with the didactics, present a case, and then have discussion among experts as well as participants. And the advisory council no longer takes part in that as a leader, but we have terribly large participation across the state in those monthly palliative care echoes. I think the thing that we're most proud of at this point is in 2021, we worked with our legislative champions to pass LD 1064, an act to advance palliative care utilization in the state. And this created a Medicaid Maine Care reimbursement for community-based palliative care that is interdisciplinary, high quality, and standardized in delivery. Also in that legislation, it requires that DHHS consult with the Maine Hospice Council and the Palliative Care Advisory Council in developing educational documents and rules related to palliative care. So again, that legislation was passed in 21. This is 24. Lessons learned. We thought that the hard part was over when we secured that legislation, and actually it's the implementation that is an awful lot of work. And I have to say that we're benefiting tremendously from our involvement with NASHP Serious Illness Institute. And I think that's really all I have to say. The other thing that we did is we had our first statewide palliative care conference presented in 2022, which was a huge success, and we're making plans to have another one next year. So with that, I will turn it over to Texas. Thank you.
There we go. Good afternoon, everyone. Jimmy Blanton. I am a deputy director for our quality and program improvement area in our Medicaid program in the state of Texas. And I just want to start by thanking the Hartford Foundation and NASHP for all their support in helping to advance palliative care. They've been there for us many times as we've been working to roll out our own program and really advance palliative care in our state. So thank you for that. It's been my honor for the past 9 years to lead a small palliative care initiative within our Health and Human Services Commission, which is where our Medicaid program is housed. That initiative started with an act of our legislature in 2015, House Bill 1874. The legislation essentially gave some legislative recognition to support what we call supported palliative care, or palliative care that is available at any stage in a serious illness. The legislation called on us to essentially work to raise awareness, increase education, increase access to palliative care services for people at any stage of serious illness, And it also created our Palliative Care Interdisciplinary Advisory Council, which is I think, we don't have a legislator on our council, but it's very similar, I think, to what you've heard. Multidisciplinary, we have participation from all the members that you'd have on a palliative care team, or at least the core members, physicians who are palliative care, who are certified in palliative care, nursing, including advanced practice nursing, social work, spiritual care professionals, pharmacy, and advocates for patients and family. And so they've been working since late 2015, early 2016. So for 9 years, going on 10 years now, to improve palliative care in our state. They've been going about this very methodically, and, starting with things like, establishing a website for information and education, or working with us to establish a website, establishing a continuing education, you could say, program where we've awarded 5,000 CE hours to our members, data and tracking related to supported palliative care in our state, and issuing recommendations every other year. And so you can see on this slide that we've had some highlights and some milestones, I think, that we're proud of between 2015 and 2023. And a great deal of this is due to the leadership that we have from our council, and in particular from our chair, who's with us and joining us, Dr. Erin Perez, who is a advanced practice nurse, a supported palliative care nurse at University Health in San Antonio. And I'm going to ask her to kind of go through some of these accomplishments and the way we've gone, the council has gone about supporting and advancing palliative care in our state over the last 9 years. So, Erin.
Thank you, Jimmy. And thank you again to NASHB and the John A. Hartford Foundation for their enduring support to advance supportive palliative care, not just for our state, but across the globe. And it is my honor and really privilege to serve along with Jimmy, Erica Dolly, multiple colleagues that are clinicians, consumers, stakeholders that are on the council, but also external stakeholders. I have participated with the Supportive Palliative Care Interdisciplinary Advisory Council since before even it became in 1874 and 2015. So I actually provided invited testimony with Dr. Zerwas, or Representative Chairman Zerwas, in 2015. And I remember that first meeting in June, where we really didn't know where we were going to go, but we all had a common goal to help those suffering with the most vulnerable disease processes. And how do we help the patients, their families, and the clinicians that are caring for them, in addition to the health systems and the state, for vulnerable, serious illness patient population. So this timeline was taken off of our Supportive Palliative Care Awareness Day, which was a bill that passed in 2023 by Senator Johnson, which really establishes an awareness day. And even the governor had sent over a special recognition proclamation celebrating the work of the Advisory Council, in addition to bringing awareness to our Texans in need. And so if we look at from 2015 to 2023, you can see that we are actually charged with a biannual legislative report. And this goes to the governor, lieutenant governor, speaker, and all of the 181 offices between the Texas House and Senate. And just so you know, in context, Texas is considered 88% medically underserved and or rural, over 254 counties. Unfortunately, we rank 50th in access. However, supportive palliative care in the Advisory Council has really pushed the needle specifically for palliative care, not just in the inpatient sector, but really trying to get momentum in the community base. And that's where NASHB and the John A. Hartford Foundation come in. We really are making strides towards a new supportive palliative care benefit line for Texas HHSC recipients. And in doing so, we've hit milestones, specifically looking at death certificate. We have a lot of regulatory challenges. However, our Advisory Council, our legislative champions, and our HHSC partners really help facilitate the momentum that we need to push bills over to pass with the governor. And most of our bills have become effective almost immediately. I can't think of one off the top of my head that didn't. So effective immediately is pretty good when it comes to a bill in the Texas legislature. Our process is actually designed to not pass bills. So we've been very fortunate since the inception to pass at least one bill related to supportive palliative care topics since the inception. The death certificate you'll see twice. One was initially it was only for physicians, medical doctors, or doctors of osteopath to be able to sign death certificate. However, the pure mass of patients, and a lot of times we have one nurse practitioner for every county. We are in a physician shortage area. And so that allowed patients that were enrolled under hospice and palliative care to actually have a physician, a nurse practitioner, or PA to sign a death certificate. And then fast forward to 2021, we realized that not everybody enrolls, especially during the pandemic, not everybody enrolls in palliative care or hospice. And so that allows every clinician the ability to sign death certificates for their patient of record that they have cared for. We've also had a wonderful chair. We have a physician named Dr. Hattie Henderson, who is my vice chair, and she has produced wonderful continuing education events. Jimmy shared earlier that we've provided over 5,000 continuing education hours. And just so you know, if you'd like to join us, we have them every year in the fall, usually in November. And consumers and clinicians learn together. We ask questions together. And so our first event was in 2017. We've modified it because of the pandemic to more of a webinar, and that seems to be more available to patients and consumers, clinicians, stakeholders, legislative members to join in online when they're available. But we've had wonderful feedback, and thanks to Dr. Henderson for her leadership in that. When you also look at NASHP had invited us, I remember going to Chicago for their initial palliative care summit, where I've met some of our colleagues and leadership, and we're all striving to see what's the best practice, what is the best pathway forward to improve the care for vulnerable populations that like supportive palliative care. We looked at Senate Bill 916 in 2019. That actually defines supportive palliative care specific from hospice, which is a different service line, in addition to creating a Medicaid study. That Medicaid study actually was the foundation for what we're doing now with NASHP and the Serious Illness Institute, funded by the John A. Hartford Foundation. But if you can see, the legislative reports continue. We're in the throes of our 2023, our fifth legislative report, and it covers everything from education, awareness, workforce, pipeline. We've been innovative in tracking our supportive palliative care board certified clinicians. And if I could ask, can we please forward the next slides? We've seen growth specifically for supportive palliative care and hospice since we began tracking and the inception of the council in 2015. So you can see physicians, we started at 275. Now we're at 583, which is more than 50% growth. Next slide, please. We have looked specifically at advanced practice nurses, specifically the nurse practitioner role, because we know that we have more available workforce for patients who need diagnosis, prescribing, and treatment for this vulnerable population. And we went from 46 that we tracked in 2015 to 116 in 2022, so over 100% growth. We also were tracking certified hospice medical directors from 2015 to now. We also have on our report for registered nurses, we also have recognized that chaplains and social work can become board certified. And now most recently, one of our PA colleagues that serves, Dr. Daniel Tomez, let us know that he is now board certified because there now is a board certification for physician assistants in Texas. So growing the program, yes, it's been wonderful to have internal, external stakeholders, but those relationships that you can foster with the legislative members, in addition to your external stakeholders, will help you move the needle forward. As you've seen in our timeline, this is not one person doing all the work. There really is a team behind this, not just in your state, but also nationally. Your experts draw upon us. We're all here to help you. If I can be of resource for you or your state, please feel free to use me as a resource. I'm sure my colleagues too would be happy to help in what we've accomplished, but also what we can do together to help you and your state move forward. I'll turn it over to Jimmy at this time. Thank you.
I think we are, we're ready to turn it back. Aaron, thank you for that presentation and all the great work. Thank you for your service to Texas and for palliative care.
Awesome. Well, thank you so much to Paul, Christopher, Lauren, Jimmy, and Aaron for joining us today and for sharing your insights on your 3 states. Before we switch to Q&A, I just wanted to quickly share that NASHB's written a brief on lessons learned for palliative care advisory councils in states based on what we learned from talking with Maryland, Maine, and Texas. And that is coming soon. And you can be notified of its publication by subscribing to the NASHB newsletter or to the NASHB Palliative Care specific newsletter. And we're excited for everyone to be able to learn a little bit more about these 3 councils and then what lessons we can take from those for other states. So we're going to now move into Q&A. I do see that we have somebody's hand raised, so you can either feel free to enter your question in the Q&A, or I can unmute you and you can answer your question that way. So I think the first person with their hand raised is Nancy. So I'm going to unmute you and you're going to be able to ask your question. So you're able to unmute if you'd like. Okay, we will go to Jill and then we can go back to Nancy if she unmutes. So next we're going to switch to Jill. You are now able to unmute yourself as well.
Okay, Ella, can you hear me? This is Jill.
Yes, we can hear you.
Okay, great. First of all, I got goosebumps when you, Texas, shared your charts, your bar charts about the growth of certifications and growth in care professionals. We're tracking it here in the state of Ohio as well. And I see we're on the tracking map that NASHB has. So I don't know of NASHB. I am not a clinician. I'm simply a girl that works in the Comprehensive Cancer Control Program. And we have a coalition, a statewide coalition for cancer care. And one of our topics of focus is palliative care for the first time ever in the history of cancer plans for Ohio. So great for you and great for us too, because we're not growing at 50% rate. But I want to ask you about these, anybody who, Maine, Maryland, or Texas, who provides these educational care hours. Are you ever going after non-palliative care persons who might come over the fence to palliative care, who just aren't yet? So, and how are you finding them, reaching out to them, etc.? Does that make sense?
Yeah. Anyone, any of the speakers, feel free to jump in.
But I can.
Go ahead. I would just speak up very briefly for Maryland. I think you've hit on a very important point. Even in building palliative care programs, you can build them, but will they come?
Right.
The clinicians that we have always struggled with, everyone in palliative care for the past 25 years knows well, the term comprehensive cancer program always rankles me a little because I can't imagine what a comprehensive cancer program would be without palliative care. Many of the patients come to you already stage 4. They're not going to be cured. So they should be introduced to palliative care the day they walk through the door while they're meeting their oncologist for the first time, for instance. So I sympathize with the question. Cardiology is a very big area in the United States where there's always more to do, and we never give up, et cetera. But there's plenty of palliative care requirement in there too. So that group, to me, is what comes to mind when you say, are we reaching out? They're a tough group. I think there are incentives now that are helping us, and the growth of palliative care in the past 20 years has helped all of us. We're on the little bit on the wave, which helps, but that's my thoughts.
Can I just mention that I think what you might be speaking to as well is just the power and the opportunity in those palliative cares helped before, the voice of community members and family members of people helped by palliative care teams. And I think that was part of the reason that Maine amended our initial legislation to include consumer and patient voice, because I think that in many communities, especially, that word of mouth and just sharing of helpful experiences can move us forward.
Hi, Jill. This is Erin from Texas. And as a council, we just had the opportunity to work with the Cancer Prevention and Research Institute of Texas, also known as CPRIT, to see what we can do to help on their strategic 10-year plan. And they break it up into 3, 5, and then 10 years. And so our council had opportunity to weigh in on their strategic goals, specifically to bring forth supportive palliative care in their planning, awareness, education, symptom management, et cetera, and really track goals. So we're excited to work with CPRIT for the first time. So thank you to Carlton Allen, who is the program manager, who's working with us. I also work at University Health System, which is our county hospital in San Antonio, through the COC. And so as the service line representative, I tag team with a oncologist who's also board certified in palliative care. But I think there's opportunity when you're doing the continuing education, you're doing community events. We open as a Texas council to anybody who would like to sign up. It's virtually, they can sign up free of charge. And so really we get people who are patients, caregivers, clinicians, maybe they are palliative care or hospice, or both, maybe they're not. And so we really learn best together. And I would offer, coming up with maybe a coalition or a support group that can help you in that educational awareness in your state. I know Ohio is wonderful to advance supportive palliative care, so there may be opportunities there, but I would just offer what we've done has really opened the eyes and hearts and minds of Texas when it comes to supportive palliative care by learning all together. Those clinicians that need continuing education hours, physicians, nurses, advanced practice nurses, PAs, social work, and chaplain all get continuing education free. And normally it's 4 hours. This year, you can hear it first, hot off the press. We have now agreed as a council, it is time to grow our continuing education event to 2 times a year, because now we have the pediatric subcommittee, which carries perinatal, pediatric, and adolescent young adult AYA. So we'll be having our adult and geriatric in the fall, in addition to our pediatric topics in the spring. And this is a huge step forward for Texas. So just a little insight for what Texas is doing on CEs.
Awesome. Thank you so much to all of the speakers for answering that question. I wanted to quickly pose a question for Scott. We have heard throughout the presentation the theme of funding and how that tends to be a barrier at times, as states are figuring out how their councils can best work to advance palliative care. So I was going to ask Scott if he, as a funder, has any advice for how palliative care councils or people interested in starting a council in their state can find funders in their state.
hope if I unmuted myself.
Yeah.
That's a great question. Thank you so much. And it's the short answer is that aging in general does not get a lot of support in philanthropy. So one place to start is many states or sometimes regions have what's known as a philanthropic service organization. So like Philanthropy Indiana or Philanthropy Wisconsin, sort of many states have these. They would be one place to start to try and make a connection to ask who are the funders, the private funders or community foundations in my state that support aging issues, or health, palliative care, sort of the whole constellation. And then it's like anything else, building relationships with program staff, presenting at various events in your state, trying to get in front of funders that way. And then as a absolute fail-safe, there is an organization known as Grantmakers in Aging, which is the national group of aging funders. And so I would say reach out to me through Nashby or directly, and we'll try and hook you up with any information that Grantmakers in Aging could provide, and go from there.
Awesome. Thank you so much, Scott. I'm just looking at the questions here. I know we had a question about whether these states have Medicaid programs that reimburse for palliative care. And I would just add that that's sort of what these states are exploring through their participation in our Serious Illness Institute. So I would guess that they would all say more to come on that. And as Lauren shared about Maine, Maine is in the process of building that benefit right now. We had another question about, it says, is palliative care available on its own, or is it usually offered with hospice care? And I think you guys would all probably have similar answers to that if one person wants to take a stab at answering that.
Well, I think that's one of the challenges that palliative care has, is that sometimes we stand too close to hospice care, and people can't tell us apart. And as we think more about messaging palliative care, we're being sort of instructed or guided to not link the two, because they are two standalone different sets of services and care, although again the overlap is the presence of a life-limiting illness.
For instance, we are not in palliative care limited to a life expectancy as you would be in hospice. That is a challenge for hospice, as anyone on this call knows, that certain patients have to choose between continuing aggressive or curative type care versus good palliative care or good hospice care. That may go away, I wonder, sometime down the road. As I said, we're not required to do that. And certainly our patients do not have to have a diagnosis that gives them a short lifetime line. But you're right, we are often confused. In my clinical practice, I often don't introduce myself as a palliative physician because it always starts off with a misunderstanding of some sort. So usually only partway through my work does someone ask me who I am, and then I say I'm palliative care, and they say, what is that? And I say, that's what we're doing right now. And they'll all say, this is good, this is what we should be doing. So sometimes you have to show it, and sometimes the words are loaded, as everybody knows.
Yes, thank you both. My next question is for any of the three states, feel free to jump in, is just generally, what lessons learned would you share with other states looking to create a council or reinvigorate an existing one? Some of you touched on some of these points as we were discussing earlier, but if you have any words of wisdom you would impart on states, please feel free to share.
Yeah. I can share from Texas, having good relationships in your legislative body, their offices, in addition to external stakeholders, in addition to your own community of colleagues, is really what that unity as you move forward, in addition to having wonderful advisory council experts. Our council is created by clinicians as well as consumer groups, and they're experts in their field. And so that helps the legislative body when you look at what are the risk benefits alternatives of creating this bill and then passing it, moving it forward. What are the implications, yes, to patients as consumers, but also clinicians as well as the state at large. But I would say gathering support together, but those relationships. So if you have a legislative member and you have stakeholders, making sure that if there's something that comes up for supportive palliative care, that they have you as a resource, whether it's email or by phone. That way you are the trusted resource to move that piece of legislation forward. And if need be, there's appropriations that you can speak to, making sure that you have great collaboration and partnerships with your health and human services. So like in Senate Bill 916, when we defined supportive palliative care and got a study, we used creative resource allocation language in there. So it did not cost as much as perhaps without that unique language. So lots of opportunities for collaboration and partnerships.
And I would say, just to add on one thing also from Texas, just stay active, no matter what. Even if you get stuck on something, it's hard. Maybe this next step we're trying to take when it comes to benefits and Medicaid, it's really hard. And maybe it'll take some time, but there's always some way that we can be providing support for palliative care. And we've tried to start things like the CE series, and now, as Erin mentioned, to expand on that. We have a website that we don't have palliative care experts within our agency really, so we use our advisory council to provide that expertise, and then they put out a report every 2 years and meet every 3 months. So it's just important to stay active, I think, and just find some way to continue to contribute and move forward.
Yeah, thank you both.
I'd briefly add that my emphasis on the legislature, it is very useful. We were mandated in the original thing, that our committee that is created by the legislature. So that's been helpful, but maintaining interest, as Jimmy's talking about, going up and down over 20 years takes, is not always the easiest thing. But I think I kind of, we're a bit of an orphan, and that's the other part that sometimes I wonder how, where we live sometimes. We're sort of a standalone and not very funded. The Attorney General's office, as Paul Ballard introduced with us, is our support, but it is, I wonder sometimes if it would be better to live within someone else's, bureaucracy. I know you'd have to put up with their rules and regs too, but, dedicated professional staff we don't have in large supply. So it's hard to get things done or sustain things with all volunteer staff, as pointed out in this, where everybody's still working and has other lives. So I put that, out as a consideration for permanence. Where do you live, and maybe who you report to. I noticed both Maine and Texas said they have annual reports. We actually don't, and I'm thinking, why don't we? So who asked to make annual reports? I don't know. Maybe I'm crazy, but I wonder if that doesn't help you keep the ball rolling. So.
I really liked what you're saying there, Chris, and that I think part of our sustainability and our little bit of success has just been because we are owned by somebody. We are owned by the recognized experts in hospice and end-of-life care by the Maine Hospice Council. So, she exists, the Maine Hospice Council exists based on a previous legislation. Everybody knows the organization, and we sit right in the middle of it and benefit from any relationships that organization's had before us. Yeah.
Well,
Yeah.
No money, but
No money.
we have one last question for the Texas team that says, how can they get on the mailing list for the CE? So if one of you could answer that in the Q&A, we will wrap things up really quickly. Thank you all so much for attending today's webinar. Thank you to the John A. Hartford Foundation for their support in the webinar, and thank you to Maine, Maryland, and Texas. When you leave, a brief evaluation will pop up in your browser. If you'd like to fill that out and provide us feedback on what more you'd like to see and how we can improve, that would be great. The slides will be posted on NASHB's website and the recording in the next few days. Thank you all so much, and we hope you have a great rest of your day. Bye, everyone.
Thank you. Oh, and the answer to that question is just send me an email and we'll get you on our list.
Thanks, Jimmy.
Thanks, everyone. Take care.
Thank you.